Okay, the last set of debate is on central serous chorioretinopathy. I invite yes for PDT from Professor Jose Rosa.
Thank you very much. Good afternoon, and I want to thank the organizers of this symposium for inviting me and to have the opportunity to come to this magnificent country. So these are my conflicts of interest. First-line treatment for central serous chorioretinopathy may include observation, photodynamic therapy, or subdermal micropulse laser. Observation, because many of the cases are resolved spontaneously, so observation is often the first-line treatment. Photodynamic therapy involves activity in verteporfin, abnormal blood vessels, and the choroid, and this releases free radicals that obliterate the abnormal blood vessels. And subdermal micropulse laser can reduce the central retinal thickness and improve visual acuity without damaging the retinal tissue. PDT was first reported in 2003 and have a direct effect on the choroidal circulation. Late and collaborators described the use of half-dose verteporfin. 85% of treated eyes show complete resolution of the nervosensory retinal detachment and or the pigment epithelial detachment, but only 1 month after the treatment. Ribarli and collaborators evaluated the treatment efficacy of a standard fluency PDT versus low fluency PDT using microperimetry. And the study found improvement of macular sensitivity following both treatments. And long-term studies have demonstrated the safety of half-dose and low fluency PDT in the treatment of this pathology. And this, the PLACE trial, comparing half-dose for the dynamic therapy versus high-density micropulse laser, the primary endpoint was to complete the disappearance of subretinal fluid at the first evaluation visit at 6 to 8 weeks after treatment, and the second outcomes were the anatomic result at the final evaluation visit at 7 to 8 months, the change in best-corrected visual acuity, the retinal sensitivity, and the vision-related quality of life. At the first evaluation visit, also at 6 to 8 weeks, subretinal fluid had resolved in 51% of half-dose PDT-treated patients and only 13.8 patients with subdermal macular micropulse laser. At the final evaluation visit at 7 to 8 months, 67% of patients with half-dose PDT versus 28% of patients with subdermal micropulse laser had no subretinal fluid. So the difference is high. At the first evaluation visit, PDT-treated patients showed a significant increase in best-corrected visual acuity and a significant higher increase in retinal sensitivity on microperimetry. However, the improvement of vision relative quality of life was similar in both treatments. Another analysis from the same trial suggested that PDT was superior to micropulse laser, regardless of whether the leak was focal or diffuse on the fluorescein angiographic exam. And in this meta-analysis, comparing the therapeutic effect and safety of the subdermal micropulse laser versus photodynamic therapy with 790 eyes from 4 randomized clinical trials and 5 retrospective studies. The results that there were no significant difference in the overall effect with central macular thickness, the adverse events, complete resolution of subretinal fluid, and treatment response. But PDT showed greater efficacy in the complete resolution of subretinal fluid. Also, in some cases, subdermal micropulse laser may be considered as competitive alternative to PDT for treating central serous chorioretinopathy. In conclusion, the choice between photodynamic therapy and subdermal micropulse laser for the treatment of chronic central serous chorioretinopathy has been the subject of several comparative studies. The available evidence suggests that half-dose PDT is generally superior to micropulse laser in terms of anatomical resolution and functional improvement in patients with central serous chorioretinopathy.